Proptosis is defined as forward protrusion of the eyeball. Protrusion of more than 21 mm or more than 2 mm asymmetry between the two eyes is considered abnormal, while exophthalmos is defined as the proptosis of eyes in association with the thyroid eye disease. The algorithm for the approach to a case of proptosis: after history taking an ocular and systemic examination and specific examination of proptosis, the provisional diagnosis is made, and after imaging, the revision of provisional diagnosis if required, and after investigation, confirmation by histopathological examination, followed by the management plan. The history of present illness: when did it start? Was it trauma-related? The progression: was it acute, subacute, or chronic? The pain: was it mild, moderate, and severe? The changes in vision: the diplopia: was it monocular versus binocular? Was it horizontal versus vertical? The skin changes associated with edema or erythema, past medical history of thyroid cancer, diabetes or HIV, or family history of cancer or thyroid. In ocular examination, we'll start with general examination, in which visual acuity decreased due to optic nerve compression or corneal exposure, and refraction, acquired hyperopia due to mass indenting the posterior pole of globe. IOP raised in thyroid orbitopathy due to restricted ocular motility, and in arteriovenous fistula due to elevated venous pressure. In eyelids, there could be lid retraction, lid lag in thyroid orbitopathy, or S-shaped lid thickening in neurofibromatosis. In anterior segment, in conjunctiva, there could be chemosis seen in severe inflammation, salmon color patch in lymphoma, and dilated episcleral vessels in carotid cavernous fistula. And in cornea, there could be exposure keratopathy due to lack of thalamus. In iris, there could be Lisch nodules seen in neurofibromatosis, and in pupil, there could be relative afferent pupillary defect. The ocular motility limitation seen in direct muscle involvement due to mechanical limitation, compression of nerves, or carotid cavernous sinus thrombosis. The optic nerve examination will start with color vision, followed by fundus examination, where there could be disc pallor, disc edema, optociliary shunt vessels, or choroidal folds. The 6 P's of orbital history and physical examination are pain, progression, proptosis, pulsation, palpation, and periocular changes. In pain, there could be inflammation of sensory nerve within the orbit, severe pain seen in orbital cellulitis, orbital abscess, vascular condition like lymphangiomas, high flow CCF, and metastatic lesion. Moderate pain seen in idiopathic orbital inflammatory disease, ruptured dermoid cyst, and trauma, and dull boring pain seen in bole erosion due to neoplastic tumor. The progression could be acute within hours to weeks seen in traumatic orbital hematoma or infective orbital cellulitis, the subacute 1 to 4 weeks seen in inflammatory orbital inflammatory disease and thyroid orbitopathy, and in neoplastic condition, the chronic more than 1 month seen in neoplastic, benign or malignant or inflammatory diseases. The axial proptosis due to lesion of intracoronal space arising from optic nerve or central space due to optic nerve glioma, optic nerve sheath meningioma, cavernous hemangioma, schwannoma, neurofibroma, or orbital varix. The downward displacement of globe seen in fibrous dysplasia, frontal mucocele, subperiosteal hematoma, lymphoma, neuroblastoma, neurofibroma, or thyroid orbitopathy. The upward displacement of globe seen in lacrimal sac tumor, lymphoma, or maxillary sinus tumor. The lateral displacement of globe seen in lacrimal sac tumors, ethmoid mucocele, midline granuloma, or nasopharyngeal tumors. The medial displacement of globe seen in lacrimal gland tumors and sphenoid ring meningioma. In pulsation, the vascular tumors, particularly those with an arterial component, will pulsate and have an associated bruit when applying the bell of the stethoscope to the globe, seen in arteriovenous fistula, high-flow carotid cavernous fistula, and aneurysm. The palpation, the mass is evaluated for the extent, border, size, consistency, tenderness, skin over the lesion. Large lesions with tendency to extend across the midline are mostly malignant. Resistant to retrodisplacement of the globe may indicate a tumor or a thyroid orbitopathy. There, in periocular changes, there could be edema present. The evaluation of proptosis, the nauseous sign, the protrusion of the eyeball beyond the orbital rim when examined from above and behind the patient, the worm's eye view looking up at the patient from below while the patient tilts his head back, the Lutz exophthalmometer from the lateral orbital rim, the cornea diameter, the distance is measured. In Hertel's exophthalmometer, the reflection of the cornea is measured in the mirror that is given. The measuring of proptosis on a CT scan is done through Hilal and Tropel method. The measurement of dystopia in case of non-axial proptosis is done with the help of two scales. In investigation, we'll go ahead with the hematological CBC, ESR, VTRL, thyroid function test, serum ANA, C-ANCA, ACE levels, BUN and creatinine levels, chest X-ray, Mantoux test, and Cassoni test. Case of hydatid cyst. In X-ray, calcification, hyperostosis in case of meningiomas, water view in case of blowout fractures. The CT scan provides detailed images of bony structure and adjacent soft tissue and is particularly useful in case of thyroid eye disease or orbital tumor. The MRI allows for the better soft tissue differentiation in periorbital, orbital, and intracranial spaces. The arteriography and venography are useful imaging techniques, particularly in case of aneurysmal lesion, arteriovenous malformation, and carotid cavernous sinus fistula. The orbital ultrasonography, useful in diagnosis and characterization of vascular lesion, other intra- and extracorneal masses, and extracorneal muscle involvement. The management general measures are lubricants and tapping of the eyelids, and the specific measures are according to the etiology.